A good day, members and guests, speakers and audience. It is our great honor and pleasure to have the SAGES new president, Dr. Liane Feldman, for the keynote lecture 3 for this virtual congress, titled The Power and Potential of Surgical Video. I'm Seon-Hahn Kim from colorectal surgeon from Korea University, Seoul, Korea. Because we are a bit behind the schedule, I just would like to welcome Dr. Feldman to the online screen. Yes, Dr. Feldman, would you give some starting message and lectures, please?
Yes, thank you, Dr. Kim. It's really a pleasure to be with you this morning. Also want to congratulate KSILS again on 25th anniversary. We at SAGES celebrate with you a great accomplishment and many of our great collaborations over the years, and appreciate the honor and privilege of speaking with you this morning. So thank you.
Yeah, can you get...
Good morning, everybody. It's a pleasure to be with you. My name is Liane Feldman. I'm the chair of the Department of Surgery at McGill University in Montreal, Canada. I wish I could be with you in person at your Congress. I have the privilege of serving as SAGES president this year and the honor of talking to you this morning on behalf of SAGES to talk to you about the power and promise for intraoperative video. One disclosure I would like to mention is a research grant from Theodore, which is a video sharing platform, an analytic platform. I will be discussing that kind of technology. I will not be mentioning any particular vendors in that space. I'd like to, on behalf of SAGES, congratulate KSILS on 25-year anniversary. We've had a close relationship between SAGES and KSILS in that time. Of course, we have a lot of shared interests in improving outcomes of GI surgery with the use of minimally invasive endoscopic and laparoscopic techniques. And we certainly have seen an amazing evolution of surgery in the past 25 years, starting with the introduction of laparoscopic surgery, becoming less invasive, more precise, more predictable, and resulting in faster recovery and better lower risk for patients. And we've had these shared interests going back, sharing panel sessions going back at least to 2013, and they're very much like this is an example of one from 2018, our World Congress. And they're often focused on concepts or themes that have to do with surgical techniques, hearing tips and tricks from master surgeons from Korea and from North America, and very much thanks to the leadership of Professor Seon-Hahn and Dr. Horacio Aspen, who is our outgoing SAGES president, who've really been the champions of these efforts. And the truth is that people all over the world, all surgeons interested in minimally invasive surgery, love these sessions that really are based on surgical techniques and optimizing surgical techniques. And we want to know how do we become that kind of master surgeon that is on those panels and teaching us and showing videos and showing us their tips and tricks. We all love those sessions because we all are passionate about the craft of surgery. It's what we love to do. We remember the first time we went to the OR, wanting to be able to do that, dedicating the years that it took to learn under our mentors as trainees, and then excited to use and perfect our skills over our lifetime. We all want to master the art of surgery. We want to know what the masters are thinking and what they're doing and how to be like that. What do those master surgeons know that we don't know yet, and how can we learn it? And up until now, it's been hard to measure what it is that master surgeons do. And so we've had to use proxy measures like case volumes, And we know there's no question that volumes of cases that a surgeon does makes a big difference for patients. This is one example. This is a systematic review of systematic reviews that really shows a strong relationship across many strong relationship across many different types of procedures that shows that the volume of cases that a surgeon does, the more cases a surgeon does, the better their patients will do. And that's true for complications, but it's also true for long-term outcomes like cancer outcomes. And it's true for, we know for certainly for high-risk procedures, complex procedures, but it's also the case for less complex procedures. Inguinal hernia repair, obviously very common operation that's done. And this is from recent guidelines and these are all randomized trials. If you plot out the number of cases from those trials, individual trials on the x-axis, and you look at the recurrence rate, it takes probably at least 100 or 200 cases to get to the point in the learning curve for a surgeon where the recurrence rate is similar to open surgery. And it's probably there's that plateau only happens after many hundreds of cases, maybe even 400 cases or so. And that's a lot of hernias. So what do experts or master surgeons do differently in the operating room? And we know that traditionally that's been a bit of a black box. But with the advent of the opportunity and ability to easily record cases using video, we can start to open up that black box and learn what the masters do and learn how to do those same things. We can define 5 domains of intraoperative performance, and those include the psychomotor skills, so what we would call technical skills. They include knowledge, personal resourcefulness, interpersonal or leadership skills, but they also include this idea of these advanced cognitive skills. And these advanced cognitive skills are the things that experienced surgeons do in surgical planning and error prevention. And basically, as the complexity of tasks increases, their successful execution becomes increasingly dependent on decision making. So basically what to do, what not to do, as opposed to how to do it or purely psychomotor skills. And we can all recognize this when we're teaching in the OR. This is really apparent when more junior learners just don't see what a more experienced surgeon sees. They don't have the cognitive schema or the pattern recognition yet. So in a simple example, like a gallbladder, a simple gallbladder surgery, they may be able to tell you that they know that they're supposed to start the dissection along the edge of the gallbladder, but if it's covered in fat, it may not be that obvious where to start. And of course, where not to dissect is as important or maybe more important as where to begin the dissection. And acquiring these complex cognitive schemas is really a big part of acquiring mastery. So how does performance in the operating room relate to patient outcomes? So if a picture is worth 1,000 words, then can calculate that a video is worth 1.8 million words. And we can use those techniques of video recording and analysis to start to open up that black box and measure and improve what happens in the operating room. And we now have much more evidence emerging about the clear relationship of operative performance and patient outcomes. So this is a landmark study from Michigan Bariatric Surgery Collaborative, and this collaborative has a large existing registry of patient outcomes for many of the surgeons, if not most of the surgeons, performing bariatric surgery in that state. And in this study, they had 20 surgeons from that collaborative who submitted voluntarily a videotape of their typical Roux-en-Y gastric bypass video. And each of these videos was edited to just show 3 components, important components of the procedure. Creation of the gastric pouch, the creation of the gastrojejunectomy, and the creation of the jejunojejunectomy. And these were uploaded to, these were distributed electronically and rated by 10 or more peer surgeons. And the technical skill was rated using a rating tool called OSATS, which is a rating of technical skill that includes respect for tissue, exposure, instrument handling, time and motion, flow of the operation, and overall technical skill, each of those rated from 1 to 5. And what they found was that first of all, there's a lot of variability between the surgeons. If they looked at the average rating on this y-axis, and they plotted that against each of the surgeons, you could see there's a very, very wide, almost double from the lowest rated surgeon to the highest rated surgeon. And then they categorize those into quartiles. So a bottom quartile, a top quartile, and then the middle 2 quartiles. And we can just take a look at what the difference looks like in the videos from a surgeon A who's in the lower quartile, and surgeon B who's in the higher quartile. You can take a look at some of what the differences in surgical technique according to these ratings from that were done from these blinded videos by peers in the state. And you can sort of you get a sense of why one might be rated a little bit higher and one might be rated a little bit lower. And then they looked at their registry and looked at the overall complication rates from this large data set, and compared overall complication rates, surgical complications and medical complications for those surgeons that they had in their bottom quartile compared to the middle quartile and top quartile. And you can see that there was a strong relationship between the technical skills rating on the submitted video and the complications for those patients. And in fact, the video ratings were more highly predictive than fellowship training, surgeon volume, or years of experience. So this was very strong evidence. This came out in 2013 for the association between surgical skills and outcomes that had previously been difficult to measure and document. Since then, we've had multiple other studies that have come out that have confirmed the same relationship from upper GI surgery, robotic Whipples, colorectal surgery, and urologic surgery. 7 of those 8 studies have found the same pattern, with higher skills scores from blinded video assessment being related to lower rates of complications. Some of them overall complications, some specific to the procedure, and also in studies of cancer surgery, in some studies showing differences in pathologic quality of the specimen or lymph node yields. So the correlation between intraoperative performance and outcomes, intraoperative performance as measured by video, and outcomes has a few important implications that I'd like to talk about now. First of all, this really suggests an opportunity to provide coaching to improve performance. It also suggests an opportunity to use to set benchmarks to confirm competence for certification or credentialing. It is an opportunity to use video analysis to determine the best techniques or components of the best techniques. And finally, what's quite exciting is that the technological advances in cloud-based storage that already enable surgeons from all over the world to share and learn from each other's videos creates the potential to use that for point-of-care decision support, either through direct telementoring through these platforms, or eventually, potentially even through automated computer vision machine learning algorithms. So let's start with the coaching. So we know that if you're a top athlete or a top musician, you don't stop being coached, even if when you're a professional, even if you're at a virtuoso. But we know that we don't, as surgeons, once we're finished our formal training, we tend not to have anybody watch us or coach us in the operating room, which is quite different from other skill-based professions. At SAGES, we are in the midst of reorganizing our educational materials along curricula that are disease-based, and you can see them listed here on the right, the different disease-based pathways, and defining educational materials. When completed, that would be part of competency, leading to proficiency, leading to mastery. And the idea is that as in mastery level, also includes coaching for lifelong learning and improvement. And that was envisioned to be done through sharing cases and video techniques. And it was envisioned to be done through existing social media platforms. And so this was created master's program collaborations for the various disease pathways that are on Facebook. They each have 2,000 to 3,500 members who are encouraged to share videos of themselves operating, as well as difficult cases. And people post the videos and are encourage their colleagues to give them useful feedback. So that's how coaching. Some examples of how coaching could be videos could be used for coaching. Another potential use of video analysis is for it to be linked to competency decisions. So right now we take written or oral exams after we complete training, but there's no formal evaluation of our surgical skills. But if we were going to go that way, that would require assessment tools that are supported by high-level validity evidence. If they have those kinds of high-stakes decisions that will be based on those assessments. But for tools that I mentioned, like OSATs, there's very little validity evidence supporting the use of those tools for competency decisions, especially for practicing surgeons. And also those kinds of generic tools, they don't provide the kind of feedback that would help with performance improvement, and they don't cover all the domains that we know are encompass expertise, as I described before. And so we wanted to have a video review as a component of the SAGES Master's program. Each of the master's pathways has anchoring procedures that are associated with the different levels of competency. And we wanted to think of video review both to support coaching and continuous improvement, as well as to confirm competency at the end of formal training, such as minimally invasive surgery fellowship. So our goal ultimately is to develop procedure-specific video-based or VBA assessment tools for each of the those anchoring procedures in the SAGES Master's pathways. Our first VBA that we're working on is for laparoscopic posterior fundoplication. This is an important procedure in the MIS fellowships, and it's an anchoring procedure in the foregut pathway masters. And this is envisioned to be a summative assessment about the ability to safely, effectively, and independently perform procedures. And so to create this tool that would have that high level or robust validity evidence behind it, we wanted to make sure, of course, that the content was appropriate. And to get the content, we interviewed 42 subject matter experts all over the world to get consensus on procedural steps, the required skills and common errors. We created a task inventory questionnaire and then distributed that to 188 other experts from SAGES to quantify the criticality and difficulty of the procedural steps, the impact of common errors, and the technical skills required. And then we created a rubric assessment which included 5 key procedural steps, 11 sub-steps, 9 required skills, and 42 common errors. We put that all together in this rubric, which includes the 5 main steps of fundoplication, and each of them includes assessments of the required skills, whether the level of risk or safety associated with achieving that task, and the quality at the end of that step of that sub-step. And we're using a video sharing platform that is able to recognize the different phases or segment the procedure into the different phases, those 5 phases that I mentioned, the 5 steps that I mentioned, and also enables raters to perform the assessment on this video platform, as well as give other comments that are not that are more qualitative. And right now what we're working on is finishing rater training and setting the pass and fail scores for our assessment. Another really exciting area for the use of surgical video is to use video to start to identify the best surgical techniques. So we all know there's a lot of variability between different surgeons, and there's very strong opinions about which techniques or which elements of techniques are best. And in fact, when we go to our SAGES or Kessel sessions, there's often a lot of vigorous debate about fine details of surgical technique. And video linked to outcomes data will allow those differences in techniques to be analyzed. So for example, this is a study of looking at technical factors related to delayed gastric emptying after robotic Whipples. And 190 videos were reviewed, and they found that technical variables associated with decreased rates of delayed gastric emptying included the flow angle, which they defined as within 30 degrees of the vertical between the stomach and the efferent jejunal limb, and other technical factors that were protective against delayed gastric emptying were greater length of the gastrojejunal anastomosis and using a hand-sewn anastomosis rather than a stapled anastomosis. So this is really interesting concept of being able to tease out technical variables related to better outcomes. Another use of video will be in trials to confirm the quality of surgical technique. And this is always a question in surgical trials, is whether we can really, they're not like drug trials where the drug is the same for anybody that administers it. This is, I think, a great example of how this could work. This is from the Color 3 trial that's comparing transanal TME compared to laparoscopic TME. For rectal cancer, and in this trial, all the videos are uploaded to this platform and evaluated with a rubric that was developed by Imperial College, which has developed really fantastic competency assessment tools they call CAT tools, which will enable surgical technique to be evaluated and also monitored in the trial. And there are the ability to use video for coaching, feedback, and quality improvement is really greatly facilitated by video sharing platforms. These are some examples of some existing platforms. They also provide what's the really exciting potential to, because of the large amount of data that's uploaded to these platforms, to begin to apply data science techniques, including machine learning and computer vision, to really ultimately help surgeons in the operating room make decisions. And some examples of how that's already being used are in identification of procedure steps, which is an important first step in achieving these goals, identification of adverse events like bleeding or bile, and automated assessment of the critical view of safety. So, for example, there are multiple groups looking at this. This is a systematic review. It just came out about machine learning for surgical phase recognition. So this is about automation of the identification of the steps and phases of an operation just based on the data inputs from the operating room. And in this systematic review, 35 full-text articles were identified that reported on this. Lap chole was the most common operation looked at, and it often achieved accuracy rates of over 90%. Although some of the challenges is that there's no consistent standardization of how each phases are defined. And several of the available platforms are already using AI for phase recognition. For example, in lap chole preparation, dissection, and skeletonization, division of cystic structures, separation of the gallbladder from the liver bed, etc. And beyond that, many groups are developing AI to identify the critical view of safety, confirm the critical view of safety, and also to identify intraoperative events like bile spillage or bleeding. And in this study, this is from a group in Stanford, where they found that for this AI analysis, there was agreement for identification of all the critical view of safety components of over 75%, and the surgeons agreed with 99% of the AI annotated intraoperative events. So it starts to create the potential to provide decision support in the operating room to avoid complications before they occur. So I showed this slide early on as an example of something that more experienced surgeons see, that less experienced surgeons might not see as readily. And of course, this is a simple example, but it certainly can lead to complications that still occur. And this is work from the University of Toronto to develop artificial intelligence models that can identify safe and dangerous zones of dissection and anatomical landmarks during laparoscopic cholecystectomy. So you can see that what this model is doing is predicting go and no-go zones. And we can see that it starts to look fairly similar to the picture the cartoon that I just showed. And we can understand how this could eventually lead to the ability to provide automated decision support for surgeons in the operating room. And through these data sharing platforms, this creates really this incredible opportunity as the AI models train with more and more cases and more data. They essentially develop this enormous body of surgical knowledge. And this group that I'm quoting here is a group that is working on our SAGES AI efforts, and they call this collective surgical consciousness. And the opportunity and promise here is the really exciting idea of being able to help any surgeon anywhere deliver optimal intraoperative care, and where we all learn from each other and from the data how to do better. So I think it'll be exciting together with SAGES and Kessels to work together, continue to work together, and to see what the next 25 years of minimally invasive surgery will bring. I'm sure it will continue to bring exciting improvements in outcomes for our patients. Thank you very much, and I hope the rest of the Congress goes well. I'm looking forward to the SAGES Kessels combined panels.
Thank you very much, Dr. Feldman, for your excellent and very valuable lecture to us. And we all are very much impressed and appreciated that SAGES has been developing a web-based platform in various directions for training and telementoring and virtual assessment, including AI technology. So I believe all audiences enjoyed your talk, because that will be one of key components for future training, with no doubt. I'm checking the live chat, but there is no question. So I may ask one question. That is, as all we know, currently YouTube, for example, many videos are also available, but the problem is the quality is not it's very heterogeneous. So sometimes it's not good for training. So I would like to ask you, as SAGES president, whether SAGES has a strategy on that potential problem for trainer.
Yes, it's a very, very good question. There's been actually studies that have shown that for surgeons, especially our residents, that YouTube is the number one source to how to prepare for surgery, how to prepare for an operation. And I have to admit that I've been in situations where I'm going to do an operation in the middle of the night that maybe I don't do very often. I remember I had a left paraduodenal hernia to do in the middle of the night, and I Googled it also. But luckily, I found a SAGES video to watch. So I think it's very important, like we said, to make sure that there is the quality of the video is going to, and it's very hard to tell on YouTube. And the studies have shown that I think, when they analyze something like the top 10 lap chole, very simple example, lap chole videos on YouTube, only less than half even showed critical view of safety and so forth. So we, like you said, organizations that are in the business of education, like K-Cells and like SAGES, the information has to be easily available through through our websites. And I think that's one of the main reasons why we're trying to reorganize all of our educational materials so that they're easier to find and that people can use them when they need them. But won't it be cool in the future if you're in the operating room, part of this web of knowledge of all surgeons connected virtually from all over the world to get the kind of point of care decision support in the operating room that you could choose to ignore or you could choose to use, just like when you're driving your car and it's beeping because you're too close to, you're going to hit something when you're parking. The same idea of putting another tool in your armamentarium when you're in the operating room. And I think that's really the promise. It's not perfect and there's certainly pitfalls to overcome, but the idea I find very compelling and very exciting for the future.
All right, thank you. We all hope that SAGES continuously takes the leading role and principal responsibility in the progress of MIS, particularly through a virtual platform for education and training and teaching under your leadership in this year. We would like to thank Dr. Feldman again for your participation in this virtual Congress to celebrate our Silver Jubilee of K-Cells Society. Thank you very much.
Thank you, Dr. Han, and enjoy the rest of the Congress.